Welcome to the Cutting Edge Health Preventing Cognitive Decline podcast. I'm Jane Rogers. One thing that's very important for our cognitive health is our ability to keep up our muscle mass. And we're seeing a lot of people going on weight loss drugs. And that is having a devastating effect for some of them on the amount of muscle they're carrying. Dr. Jeffery Galvin is founder of Vitality Medical Wellness in Charlotte, North Carolina. And he's seeing this in his patients, and he's very concerned. So he's been a guest before. He's back on to talk about how to prevent this. Dr. Galvin, thank you once again for joining us. I so enjoyed you as a guest last time, and I appreciate coming back on.
Oh, it's my pleasure. It's great to see you again.
Thank you. So you wanted to talk about something that isn't usually something that we talk about with this audience, but it relates to cognitive decline. What's on your mind?
Well, I think that one of the things we've been seeing quite a bit with this explosion of weight loss drugs is people coming to us that have lost significant amounts of lean mass along with their weight.
Lean muscle mass.
Lean muscle mass. And there's a very, very compelling connection between the amount of lean mass you have and cognitive function as we age. And it's a very inverse relationship, meaning that the more muscle you lose, the higher your chance of having cognitive decline. And, you know, when we talk about medications for dementia and cognitive decline, you know, the list of medicines that work is essentially zero, right? Well, there is a medicine that works really, really well. It's freely available to everybody, and it's free, and that's exercise. And if we can maintain muscle mass, it can have a really massive improvement in terms of our cognitive health. And one of the things we were chatting the other day is this rise of these weight loss drugs and the unintended side effects of really massive amounts of muscle mass loss, and the combined problem of the very significant difficulty of regaining that muscle if you're above 50, especially if you're female. And so I thought that would be
it's
interesting.
It's really interesting. Okay, so what are you seeing in your patient population? You're seeing women very surprised by how much muscle they're losing on these things, and significant muscle.
Yeah, so, you know, as you know, we do these pretty extensive executive evaluations, and part of those evaluations, we do DEXA scans on everybody. And DEXA is the gold standard for looking at body composition, and we can directly measure fat mass, but also lean mass, which is muscle and organ weight, as well as bone density. And when besides doing these sort of high-end executive evaluations, we do a lot of just standalone DEXA scans because it's hard to find them. And so we have a lot of patients that just find us on the web and they just come in for a DEXA scan. And I may or may not chat with them a little bit. A bunch of these people we've seen over the last few years have gotten a DEXA scan, and then have gone to their doctors and have been prescribed Wagovi or Ozempic or Mounjaro or Zebound or one of those drugs, and have come back for a repeat DEXA scan 3 months later, 6 months later. And my staff kind of comes and they're like, Dr. Galvin, look at this patient. And you know, we realize, oh, you lost 30 pounds, but 15 or 20 of that was lean mass. And that's a huge problem because those people that lose that amount of weight, their body fat percentage actually goes up. And you know, from us talking, like, I don't care what you weigh. I really don't. What I care about is your body fat percentage, because that's the real measure of health. And if you lose 30 pounds, but 20 pounds of it is muscle and only 10 pounds of it is fat, your body fat percentage actually goes up, which has a real impact on all-cause mortality, on cognitive function, and things like that. And why is that happening? Well, it's happening because of the nature of these medications. You know, these medications are what are known as GLP-1 agonists or combination GLP-1 GIP agonists. And what they do is sort of it acts on multiple different levels. On one hand, they lower GI motility and gastric emptying, so you feel full longer because it takes longer for food to transit out of your stomach and longer to transit through the GI system, and that can be helpful. Secondly, it has an effect on insulin metabolism and response, and you become more responsive to insulin. We've used metformin as a form of weight loss for about 15 years because of that same effect. If we can lower insulin levels, what we know is we get weight loss because, insulin in high levels tells us to store energy, in particular store fat. So if you can lower insulin levels, you can drive fat loss. And so it does that. They have an effect on leptin, which is a hormone that releases from the gut as we're eating to tell our brain that we're full. They also have an effect centrally on the brain of turning down appetite. And so all those things are really good to lose weight. But again, is weight loss really what we want if we're going to have the unintended consequence of increasing our risk for all-cause mortality and dementia as we age? And so what's happening more and more frequently is primary care doctors like, oh, it's easy. I just give them this medicine. They lose weight. And what happens is people essentially stop eating. And when they stop eating, what happens is your body flips into that starvation mode where it starts to want to hold on to fat because fat is our emergency energy source for a rainy day, and instead starts burning through lean muscle and connective tissue. And we get this unintended consequence of a lot of lean muscle mass loss. We know that we lose, as we age, we naturally lose muscle mass, and it's important that we sort of understand that. But if we do something to accelerate that muscle mass significantly, it can really have long-term consequences. We know that there's a difference between mortality rates, all-cause mortality rates, between the people who are at the lowest 25th percentile of muscle mass and anybody above that. And those numbers can be, 40, 50, 70% improvement in all-cause mortality over the next decade. And so where do you want to be? We're always trying to store muscle. The older we get, the harder it is to add muscle.
And you're wanting to get women, I know, above the 70th percentile, ideally?
Yeah, ideally above the 70th percentile. And it's hard. I had a couple that came in last week, and they're in their late 60s. He's, I think, early 70s. And she was under the 5th percentile for muscle mass. Now, she looks very thin and, looks like she's very healthy, but that's a significant problem. And, I think a good way to visualize it is that, that stereotypical elderly person that's sort of walking and they're like, got the cane and they're like, they're shuffling. Well, why is that? I mean, that person doesn't have Parkinson's. What they have is a profound amount of sarcopenia, which is muscle loss. And they're very prone to falls and injuries. We know that once you hit age 50, the number one cause of accidental death is fall related. If you're age 75 and you fall and break a hip, what's your mortality rate at 1 year? 40% of those people die. Is it, I'm an ER doctor and like we see hip fractures all the time. Are they dangerous? I mean, look, they're painful and you need to have surgery to fix it, but are they, it's not like a blood clot. It's not like a heart attack where you've done permanent damage, but what happens? Those people lose mobility, they lose more muscle, they lose independence, and they get the dwindles. And we all know somebody in our life who was, spry and older, and they fell and broke their hip, and a year later they're gone. I mean, I think almost everybody knows somebody like that. What's going on? Well, it's that combination of loss of mobility and loss of independence. Now, how do we prevent hip fractures? Well, there's a recipe for that. We start working on them when we're younger, 40, 50, 60 years old. We measure bone density to find out where we are. And we know that strength training is a key piece of that. Our recipe for women is typically strength training, vitamin D, and hormone replacement and optimization, particularly estrogen. That combination, we've taken many women with osteoporosis over the years and gotten them back to normal. Typically, women are losing, 2 to 4% bone mass a year on DEXA. And we do that and we start seeing them gain to, 1 to 2 to 3% a year. And we can reverse osteopenia, we can reverse osteoporosis. But the key piece of that is strength training. Actual, weight bearing exercises are key. And that's, I think, one of the things we really worry about with these, particularly with these drugs.
And you and I have talked about how hard it is to gain muscle mass. I didn't have enough. And so for the last 9 months, I've been a gym rat, and I've gained, but I've worked so hard, but I've only gained 4 pounds of muscle. And if you're talking,
and it was hard fought.
Yeah. If you're talking about women losing 15 pounds on these drugs of muscle mass.
I was sharing with you earlier that we had a woman that came in and had lost all this, lost 15 pounds of muscle. And it's probably, and the other thing is that they don't feel good. That's the other piece is like, yeah, I'm lighter, but they look, you can kind of tell, like they talk about Ozempic face, like where they look gaunt. Well, because a lot of that is sort of this loss of muscle, and they don't feel good. They don't perform well. And for that woman that's lost, 15 pounds of muscle, that is probably a multi-year process to gain that back, working very, very hard, just to get us back to normal. And she was low to begin with, as most women that we measure are not above the 70th percentile. They're oftentimes much lower. And so it really becomes a problem. Now, we've had a lot of experience with these meds, and we were probably one of the very first places in the country probably to use them because we'd been using metformin so long, and those GLP-1s came out and we said, oh, this is like super metformin. Let's try it for weight loss. And we did it. And what we found was, and we're always very careful about muscle mass. And what we found was that, people started losing lean mass like they often do with weight loss. And we have a protocol for that. And what we typically see is that, whenever you lose a significant amount of fat, you're going to lose some muscle with it. Generally, if people are obese, it's not usually that big a problem because the fact, if you're 70 pounds overweight, guess what your muscle mass tends to be? It tends to be really good because you're carrying 70 pounds of extra weight with you. Yeah. So for people who are obese, I expect them initially to lose maybe, if we lose 20 pounds of fat in 3 months or 4 months, we're going to typically lose 5 or 6 pounds of muscle with that. That's pretty normal. But again, we're starting with obese people usually at a little bit higher level. And then what we see is that on DEXA scan, we see that sort of parallel little drop of muscle and fat. But once we see that, we kind of implement some of these other protocols, and the muscle starts coming back and the fat keeps dropping. And we're always talking about the delta on the DEXA scan. The delta is pounds of fat lost plus pounds of muscle gained. So it's really important. And with those, we have exercise physiologists on staff, and we're always talking about strength training as well as some aerobic component. A lot of times we're using zone 2 training to maintain that VO2 max. And also we're talking about getting adequate amounts of protein, which is a challenge when you have a medicine that's suppressing appetite. Trying to get enough protein, which also is an appetite suppressant, can be challenging. So we do all kinds of things with shakes and fat bombs with protein powder and putting protein powder in coffee. And there's a way to do it, but it really requires close monitoring. So our exercise physiologists are typically meeting with people almost on a weekly basis to encourage them, see what, what are you doing? And we have the devices to measure, not only, we typically measure with DEXA quarterly, but we also have some advanced devices. We have a couple of advanced Tanita devices, similar to an in-body scanner that uses impedance-based measurements, but we can get a sense of, are we losing fat? Are we losing muscle? What's going on? And it allows us to do mid-course corrections. If we see consistent muscle loss over a couple of weeks, we kind of intervene at that point. And we've been very, very successful. And almost none of our patients I've got patients who have lost in excess of 100, 120 pounds and gain muscle in the process.
So what you're saying is you just have to be smart. You have to be really smart about it.
You have to be really smart about it, and you have to be able to monitor. And, most primary care doctors are really not. They don't even realize it's a problem. First of all, they're just writing, the amount of effort they're putting in is, they're taking their pen or their mouse and they're ordering the prescription. And they might give you a sheet of, here, you should eat better. What does that mean? us, we use glucose monitors, we use, genetics, epigenetics, we have detailed lab work. We can, people always, a lot of doctors are always asking me like, why do you have such a high success rate with your patients? Our success rate rather is probably in excess of 85-90%. And the only time people are not successful is what?
When they're not following.
They don't do. Yeah. And again, and it's not because like I'm the world's greatest doctor. It's just that we have all the tools, that I have all the information. I don't have to guess. I know. Mm-hmm. Like it's simple. Like I know what's going on because I have all this data, and I can say, well, physiologically, this is what's happening. And because our physiology is all the same, if we do this pretty much has to happen. And again, and we have glucose monitors. I have a patient today, and, I've known her for years and years and years, and she's a very smart lady, very successful lady, but she won't listen to anything that we tell her. And, she came in very, very frustrated, last week, and she knows lots of our patients, and everybody's doing really well. And and luckily I've had a long relationship with this person, and I had to have the right, kind of read the riot act to her. I said, listen, you're not doing any of the things that we're asking you to do. Yes, I am. I'm eating. I go, no, you're not. I have a glucose monitor on you. I can see what you're doing. Like you're not it's clear you're not doing this. And, and it's simple. Like, it's like the old joke about, the doctor prescribes the medicine and the patient comes back in 2 weeks later and, he goes, hey doc, these pills don't work. And the next question, are you taking them? No, I'm not. Okay. Well, they don't work so well in the bottle, And so I think that that's important, that you have to really understand that. And it can be done on your own, but it's very difficult. And you know how different 4 pounds of muscle and how we've fought to do it. I mean,
yeah, hard, very, very hard. Also, I've worked hard in increasing my protein level. And so when you're working with someone who's on a weight loss drug like Ozempic, what kind of protein are you wanting them to take in a day?
I mean, ideally, we'd like to see a gram of protein per pound of body weight, which can be tough, right?
Wow. And
generally per pound of ideal body weight. So, but if we have someone like a female that comes in at 180 pounds and one of the questions, like we don't really use, I'm going to give you a little trick of the trade from many years of doing this. What is your best weight? Like what is the healthiest weight for you as an individual? Mm-hmm. There's all kinds of charts and and people get very frustrated because they look up their ideal body weight. And it's always like, I haven't been that weight since I was 12 years old, kind of thing. And the problem is that all those charts are wrong. What's the best question to ask somebody? Because they'll always give you the right answer and they always know the answer. What weight do you feel the best at? And invariably, that's right, almost always. And in women in particular, they can tell me exactly how much they, and so that person that's 180 pounds, their ideal body weight is 120. I ask them, where did you feel best? I felt best at 138 pounds. And it's always like that. It's not like, it's always a number, like at 138 pounds. And so I say, okay, our goal is 138 pounds because that's what's right for your body. And almost, they're never wrong. Like they're never wrong. It's uncanny.
One of the things I've noticed in this conversation is that you're saying women on the weight loss drug, women. Are you seeing like 95% of the people, women, and men aren't really subscribing to this thing?
Can I tell you the difference between men and women?
Well, there are some differences. Yeah.
I'm going to make the men mad and the women are going to all agree with me, is that women are way smarter than men in a lot of ways, and men are dumb. But we all do better than the women. Why is that? Because all a man wants typically is a plan. Give us a plan and we'll execute it. And we'll execute it without thinking about it. The joke I make with my patients when they're here, especially when they're come as couples, as they often do, is that if I say to the couple, I say, listen, or I say to the woman, if I ask your husband to walk from this end of my office to that end, he's going to do exactly that. If I ask you to do it, you're going to walk and be like, oh, are those your daughters? Oh, they're beautiful. Oh, I like the color of this. I like this plant. Like, we're wired differently.
We are.
And men will just blind, like, we just want to plan. And so with our men, we say, hey, we want you to do this diet-wise. We want you to do this exercise-wise. And they generally do it. And they still can lose muscle mass. It's just a lot easier. The other thing is that there's the hormonal piece. And we're always talking about optimizing hormones. Men have a lot more testosterone at baseline, and when we optimize them, their levels are a lot higher. So their ability to add lean mass is a lot higher than women. So we run into the problem with just intrinsic ability to add lean mass is a lot higher in men when we get them dialed in than it is in women. And like many other things, women have to just work harder than men do. Like, we just dumbly, we don't appreciate the fact that we have it easy in a lot of ways. We still have men that lose muscle mass, and we have to kind of like, again, get, intervene and sort of really get them. But generally, the muscle loss piece, it's going to be the same in men and women if you go to your primary care doctor and they don't do anything else. For us, because we're so dialed into it, we see that women struggle with it more because it's a lot harder for women to kind of get those protein levels, to add the strength training, because very often it's something that they're not used to doing. They walk, or they do different yoga and Pilates, which are really not strength. Actually lifting weights for a lot of women is somewhat of a foreign thing. And so we have to sort of build those habits, where men are a lot more kind of used to it. It's probably what they were doing anyway. And so that's kind of we do struggle with it with women to a greater extent than men because of just sort of intrinsic differences.
Well put. Anything else you want to add?
Yeah, so there's some interesting, we're always kind of looking ahead, right? And there's actually an interesting drug in the pipeline that is being studied that is a monoclonal antibody. And I wrote one of these crazy names. I wrote it down here somewhere. Bimagrumab. They've run out of names, right? They've got to just make stuff up. But anyway, it's a protein that they're studying. It's a bit problematic because it has to be given IV. But there's a study that came out over 48 weeks of getting this sort of, I think it's 4 IV sessions of this drug. The study group lost 20% body fat, which is a huge number. I mean, numbers we see with semaglutide or 6 to 10, some of the tirzepatide maybe up to 12, 15%. So this showed a 20% drop and, importantly, a 4% increase in lean mass, which is the only, has not been shown. All the other ones show drop in lean mass. That's in the pipeline. It's, I think it's a phase 3 study now. Again, it's IV, so it may not be a great option, but there are some, it's a very known problem with these drugs. And again, kind of circling back to cognitive health, we know there's a very strong correlation between cognitive health and muscle mass. And why is there that relationship? Well, muscle actually, kind of secretes certain chemicals essentially that, have an effect on neurogenesis and inflammation and things like that, things that are tied to cognitive health. So the more muscle mass we have, the more we're releasing these sort of kinins that are associated with these things, and they cross the blood-brain barrier and they have a direct effect on the brain. So just if you want to oversimplify it, your muscles actually secrete brain juice, essentially. And if you have more muscle, you get more cognitive improvement. And if you have less muscle, you have less of that. And so that may be a simple way for kind of the viewers to kind of think about, if I want to link muscle mass to cognitive health, think about these proteins that muscles secrete that are like, brain juice, essentially.
Yeah. Well put. They can get that. I can get that. Thank you.
Very scientific.
Brain juice. Thank you so much for your time. I always enjoy talking to you. It's such a pleasure.
It's always great seeing you.
Thank you.
Thank you for having me on again.
Thank you. You have an awesome day, okay?
You too.
I will. You've been listening to the Cutting Edge Health Preventing Cognitive Decline podcast. Any information shared here is for educational purposes only. Guest opinions are their own. This podcast is not responsible for the veracity of their statements. Do not use any of this information without first talking to your doctor. Cutting Edge Health, LLC, is not responsible for what may happen to you if you use their information in place of official advice from a medical professional. Thanks for listening. Be well.